Hello, everyone, and welcome to the SAMHSA Center for Integrated Health Solutions Communities of Practice on HIV and Opioid Use, Integrating Overdose Prevention and Harm Reduction, Making a Difference, Part 3. Our slides are created by Nikki Miller and Linda Frazier from Advocates for Human Potential. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, the Health Resources and Services Administration, or the U.S. Department of Health and Human Services. Neither the presenter nor creators have any financial relationships to disclose. We're going to welcome you to the third in our series of virtual COP webinars. This session is the third in a series of 3 30-minute COP sessions that are on-demand webinars. After viewing, please follow the link to give your immediate feedback. Any questions received will be answered by email or by follow-up TA requests based on the session content. This format is designed for maximum learning on your own schedule. And now I'd like to introduce Aaron Williams, our presenter for today.
All right, thank you. So today we'll be talking a lot about overdose prevention, harm reduction. So looking at ways to prevent, death, really, which is something as a part of the opioid crisis, in this country that we really, want to focus on. So helping organizations think through what kinds of resources that they would need in order to, prevent premature death. So we're thinking about, this issue of overdose prevention, risk reduction. So we're going to look at a couple things. So thinking about social determinants of health, the opioid epidemic, looking at the intersections of the epidemic, looking at some of the demographic and risk factors, and then thinking about overdose prevention versus emergency intervention and Naloxone Basics. So we'll talk a little bit about that as well. All right, so when you think about this, looking at, some of the data that's happening, some of the data right now that's occurring, the current situation threatens to become a perfect storm with the opioid, HIV, and viral hepatitis epidemics intersecting in dangerous ways. That's the director of the Office of HIV, AIDS, and Infectious Disease at the CDC. So really thinking about, this as a significant public health problem. Lots happening in terms of increased risk for both hepatitis C and HIV. So when we look at some of the data and begin assessing the evidence, so overdose deaths from prescription opioids were higher among whites, American Indians, and Alaska Natives compared to blacks in 2016, although that's beginning to change, and we'll talk about some of that data shortly. A lot less is known about race, ethnicity regarding overdose deaths due to illicit opioids, but we know fatality rates can vary from up to 6-fold across geographic regions. Early epidemic dominated by the abuse of pharmaceutical opioids, but the proportion of deaths involved illicit opioid trends is now trending upward from 40% to 60% in 2016. So you see kind of a transition of the opioid epidemic from pharmaceutical substances into more illicit drugs, and with that is bringing much more in terms of increased risk of death. Again, looking at some of the data here, really, we're seeing this kind of, change in trend. And this chart really looks at, the opioid overdose deaths related to more, gun and motor vehicle deaths, and look at the trend over the last, 15 to 20 years, and you see, overdose death beginning to dramatically outpace, both gun-related deaths and motor vehicle crashes. So in the late 1990s, U.S. pharmaceutical opioids began to penetrate much more than in the prior 6 decades of illicit opioid trafficking, making previously unaffected areas highly vulnerable. Substances misuse multiplies a person's risk of HIV via drug injection equipment and unprotected sex. So when we think about substance use and overdose death and some of the risk factors here, really thinking about some of the current demographics. So age range, folks between 49 and 64, typically males. Currently, epidemic is looking much more at white, American Indian, Alaska Natives, although again that's beginning to change some. Some past criminal justice involvement, Veterans, some veterans engaged in some of this activity and are having difficulties in terms of early death. Um, Medicaid has also been prescribed some form of the opioid, prescription opioid in the past. Many of them have some sort of diagnosis of mental illness. Folks living in the rural settings, Midwest, and in the Northeast. Again, although some of those geographic, demographics are beginning to change, you also have these other factors where you have current alcohol use of benzodiazepines, other sedatives, and all of these things are sort of multiply the risk of folks, folks in terms of premature death. So when we think about some of the changes and some of the transitions here, you're beginning to see more fatal overdoses in urban areas. You're beginning to see sort of a change, a transition towards that. Thinking about some of the stereotypes, beginning to kind of move through some of the mythology. In terms of what's happening, you're seeing really sort of an uptake in in urban deaths in urban centers now, D.C., Baltimore, other urban areas, and using heroin, having the pure forms of that coming through, and being laced with other substances such as fentanyl or other synthetic opioids, really increasing the risk of death. Again, so thinking about this, individuals recently released from custody or incarceration, up to 129 times, the risk of overdose for those folks. People who are coming out of incarcerated environments who may have had a substance use disorder going in, may not have had treatment while inside, are coming back out and wanting to use substances again. They're a really, really vulnerable population in terms of risk of overdose. So here, this chart is really talking about what I said earlier, which is the changing dynamic of this particular epidemic. So you're beginning to see states and other geographical differences beginning to change. So 6 states have now reported higher opioid overdose fatalities among blacks than whites. 1 state reports higher fatalities among Hispanics than whites. So you're beginning to see a very much a change in sort of the dynamics here. Across the country as the data continues to come in. So when we talk about this, we want to make sure that we're making some distinctions here. Overdose prevention, versus emergency measures. The medication that we'll talk about here in a second, naloxone, is administered in overdose emergencies, is a heroic life-saving measure, but it is not a preventative measure any more than defibrillators are preventative measures for heart attacks. So I think we really want to emphasize that point that naloxone is a life-saving medication for emergency situations, but there are other things that you can do that really are better suited to the idea of prevention, ensuring that people don't use or limiting their risk of harm from using. So just to talk about some of the basics here of naloxone, since this is something that is very much a part of this conversation. It was FDA approved in 1971 to reverse opioid overdoses. It has a nasal formation that was recently approved, for community use. And what it essentially is a short-acting opioid antagonist, meaning it blocks uptake of opiates to the receptors in the brain. Has a half-life of about 30 to 90. And that can outlast, blocking effects resulting in death. So essentially, when you use the medication, it knocks the opiates off the receptor, and people, typically come right back. Multiple naloxone dosing is required in many regions. That's typically because they're using some very powerful, opioids, maybe fentanyl or some other things. So you may have to dose, more than once. So deaths from synthetic opioids are up 88% from 2013 to 2016, according to the CDC. 426% increase in illicit opioid drug seizures, testing positive for fentanyl. Again, that's another very powerful opiate, that is very much involved in some of the overdose deaths that we're beginning to see. Um, Always calls for EMS get revived individuals to hospital. Ensure clients, staff and bystanders training and administration know these critical action steps, especially in some of the high-risk geographic regions. So when we think about, this particular, element of the crisis, there are lots of components to think about when we talk about this idea of, harm and risk reduction. Again, thinking about, use of naloxone as kind of the emergency setting. So what do we do when we talk about just harm and risk reduction? There are a number of different things. Reducing vulnerability by increasing access to services, looking at the environment, removing some barriers to service, really thinking about a more public health approach, to substance use, what are the availability of treatment services or recovery support services? How do you get people sustained and maintained in recovery? Are you, actively, seeking folks out in various settings that may have, risk factors for, opiate use, opiate overdose? So really thinking through those, kinds of, processes, as well as making sure that some of these life-saving medications are available more widely in the community. All right, so again, when we think about this, there are a number of options, particularly if you're looking to integrate something into your HIV care settings. So thinking about some of these harm reduction, processes. So clearly, client or patient education about safe use or injecting. What are your educational materials? How do you think through that? If you don't have those services available, can you link to other services in the community related to that? Providing some information around MAT, so medications for, substance use, therapy. So thinking about those medications that really are effective for opioid use disorders, and how do you get people access to that? You're looking at training on naloxone, so making sure that enough people in the community are actually trained to use naloxone. So thinking about how you do that in terms of your own staff and community members. Looking at overdose risk, so actually doing formal assessments to figure out what someone's overdose risk may be, and then having that as a part of their chart or medical record in order to really help people think about how to provide these services. And also needle exchange, so thinking about other harm reduction processes. If you aren't doing those things, you have access to other coalitions and others who are. All right, so screening for opioid overdose risk. Again, that's a big component of this. Looking at the screening for that and making sure that you actually are taking into account those risk factors. So if they have a history of injection drug use, if they have a prior overdose incident, high levels of intoxication from both alcohol and opiate use, if they're using multiple different drugs, particularly benzos, history of co-occurring mental health issues, especially depression and suicide, comorbid other chronic health conditions such as HIV. So really thinking about all of those risk factors. So if those things are there and in place, you may want to really engage in some overdose risk prevention strategies. So signs of an overdose and response. So again, rapid depression, respiratory depression, excuse me, can happen either minutes or hours after ingestion. Try stimulation. Try stimulation to get them to wake up. Person's non-responsive, begin rescue breathing. Call for help, 911. Recovery position, lay on side with knee bent, face turned to the side. Administer naloxone if you have it, and then get them to the hospital. Again, this slide really sort of demonstrates kind of exactly what you need to do. Spells it out in really clear sort of form around the use of naloxone and really how to help in those emergency settings. All right, so when people think about safer use, which is again a part of this process, really thinking about some principles there. So not using alone, really educating people about this. You're not using behind locked doors, not mixing substances. Have some level of understanding of the source of where your goods are coming from. Be mindful of what your tolerance is. Know where overdose emergency sites are. Do not share equipment. Have some naloxone available with a friend or someone close to you. Think about if you want to actually engage in treatment use of medication-assisted treatment services. Not using or sharing needles. So these are a number of things that people can do in order to be much safer, and making sure that you have some sort of process to educate people about what those things may be. So when we think about this other community-based models in terms of getting people services, what we call the low threshold model. So basically, in terms of people coming into services, you address some of the basic health needs. You're really engaged in a lot of outreach. You have available sort of drop-in services. So really thinking about how you do that. These organizations also providing trauma-informed services. So really, making sure that you're having not a lot of barriers to services.
And now we're at the Are you ready to implement overdose prevention and risk reduction in integrated care settings? When you think about this, there are a number of things you want to make sure that you're ready to move forward with. So one of the things is you want to take a look at what the relevant laws are in your area. There are state, county, and other federal and local laws around what you can do as it relates to overdose prevention. So you really want to know what those are and what's available. And certainly other resources are available to you as well. A lot of harm reduction cards, other materials. You'll see the SAMHSA Overdose Prevention Toolkit, the North American Syringe Exchange Network, and the Harm Reduction Coalition. So those are all hyperlinked and resources that are available to you and that you can access with the slides. You'll also see other links and resources we've provided. SAMHSA resources, that would be the Substance Abuse and Mental Health Services Administration. There's also harm reduction and safety education courses, National Harm Reduction Coalition, and other treatment options, particularly for minorities, and other culturally appropriate resources that you'll see at the bottom there. And if you have any questions about any of these resources, you can always reach out to us. So thank you for spending time with us today. I hope this information about harm reduction and how to actually implement these services in your program was helpful. We have the citations in this part of the slide deck, so just in case you want to look at some of those references, and also these slides can be downloaded at the CIHS website. So if you do have questions or you want to see more resources, you can always go to our website, see the link that is provided there. There's also our information here as well, www.integration.samhsa.gov, or you can email us any questions you might have at integration@thenationalcouncil.org. And if you'd like to talk to Aaron, the presenter, or have other questions about what was shared in this particular COP, you can send him an email or give him a call at that number provided. So thank you so much, and good luck to you as you go forward implementing these services.